is the immune system? Acquired versus innate. How does the body defend itself? And so a little bit deeper into that is cell-mediated versus humoral immunity. And last, the complement system. Acquired adaptive immunity. This type of immunity is something that your body adapts to. It is not going to be fast. Your body will literally make antibodies and adapt, and it can form an immune response that can be quicker next time. And this adaptive immunity is T and B cell mediated. What's an antigen? Antigen literally means antibody generator. Your body sees it as a foreign object. It's usually a large molecule. Some of our anesthetic drugs are antigens. For example, protamine and dextrins. They're pretty large molecules, and they are complete antigens. An example of a hapten is a drug or drug metabolite that binds the cell membrane, and then it becomes foreign and alerts your immune system. Cytokine, chemokines, these are proteins that are important in cell signaling. I'm going to talk a lot about cytokines and then the types in this lecture, dropping that word a lot. And these are important in cell signaling. So interleukins are abbreviated IL dash whatever it is, are released by leukocytes. Lymphokines released by lymphocytes. And remember, lymphocytes are that umbrella of the white blood cell, same as leukocytes, tumor necrosis factors, interferons, and they modulate the balance between cell and humoral mediated immune systems. So remember, cell mediated is what? T cell. Humoral is antibody, which is B cell. These basically, when they're released, pro-inflammatory factors. They're telling the body and other cells and basically saying, hey, something's going on here. A lot of times when these get out of control, that's when you get as well some too much inflammation, as in RA, and that's why people are put on anti-interleukin or anti-TNF, specifically targeted at these cells to suppress the immune system. I'm going to quickly talk a little bit about cytokine storm. That word has popped up on my radar recently regarding COVID-19. Basically, what a cytokine storm is, speaking of cytokines, this virus specifically invades cells really quickly and basically a huge immune response. So the virus is infecting cells, lung tissue, heart tissue very rapidly, and the immune system is trying to keep up. So lots of cytokines are being released at once. And remember the balance of your immune system. So under immune system, infection can kill you. Over immune system, autoimmune issues and inflammation. The body is overrun with cytokines, too many of them, in fact, and signaling cell death and inflammation and cell aggregation and coagulation, microemboli. And they're finding that there's a lot of cell death going on at once. And a lot of the medication is directed towards attenuating the immune response, like telling the immune response to chill out so that so much cell death, kind of starts to reverse itself while the body's trying to fight the infection. So there's a lot of interplay between letting the immune system do its job and then the virus just overtakes the body. The immune system really gives it a good fight, but overdoes it. So I know that the Chinese researchers, they've been dealing with it for a few more months than we have. They've been doing small population studies on postmortem death or those that are severely ill with COVID and finding there are higher levels, sometimes up to 50 times higher, of cytokines, interleukins, et cetera, in these patients that are severely ill or dying. To me, that's interesting just to note that this is a big reason why people are getting really sick really quickly. Cell-mediated and humoral immunity. Cell-mediated is intracellular. Immune cells are directed at a pathogen, so cell-to-cell immunity. And these are the T cell system. Humoral is extracellular in the body fluid or humor, and they're mediated by antibodies secreted by the plasma. And these are the B cells. So within the acquired adaptive immune system, there are two responses: cell-mediated T cells, humoral B cells. A little bit about lymphocytes. Lymphocytes are a type of white blood cell. So we're going to talk about other white blood cells later in the lecture, but these are a type. T cell and B cells and natural killer cells that we're going to specifically focus on. T cells are differentiated in the thymus and are activated when bound with antigens and secrete mediators that regulate the immune system. Three types of T cells. There's helper, suppressor, and cytotoxic, or killer cells. B cells are differentiated in bone marrow and the liver. When they're activated, they form antibodies that act directly and indirectly. Natural killer cells are part of the innate immune system, recognize antigens in the absence of antibodies. So that's the other immune system. So we're talking right now about the acquired adaptive immune system, T cell, B cells. The NK cells are part of the innate immune system. Those do not require activation. Okay, so antibodies. And remember from the previous slide, antibodies arise from T cells or B cells. It's B cells. So on the outer surface of the B cell, antibodies will form. And these B cells are immature. So whenever an antigen arises, the B cell forms a specific antibody to the antigen. And they will directly attack the antigen and indirectly activate the complement system. Ig simply means immunoglobulin, and there are 5 classes of antibodies. The most prevalent is the IgG, and then IgG involves allergies. And beta cell activation involves an antigen that binds to the membrane-bound antibody B cell. B cells can differentiate or divide into 2 different types of cells. So a memory cell and a plasma cell. The plasma cell, located in this lower right picture, is simply a non-membrane-bound B cell that just spits out antigens, so then go and seek out pathogens and seek to kill them. Cells, again, there's 3 types. suppressor slash regulatory helper, cytotoxic slash killer. Two different types of receptors express. Suppressor express CD24 and CD25, and if the suppressor or regulatory are not functioning, an autoimmune disease occurs. So these T cells work to really suppress the overactive immune system. It's kind of the mediator, like calm down, chill out immune system. And that's why if it doesn't work, everything else can overrun it and cause the immune system to get overactive. Helper helps activate beta cells, cytotoxic T cells, and other immune cells, and these can make lymphokines. An example is interleukins, and then cytotoxic, which are basically killer cells they seek to kill. Cells do not recognize antigen like B cells do. So remember, B cells have antibodies that recognize antigens and then they bind with those complexes. T cells rely on indirect methods. They respond to major histocompatibility complexes. These are proteins on the surface of macrophages, B cells, and dendritic cells. MHC1 present to cytotoxic T cells, and MH2 present to helper T cells. So these are helper antigen presenting cells so that the T cells kind of know what's going on. It kind of gives them a clue of, hey, these cells, things up with these cells. And this is just a recap from the last slide. The MHC2 protein receptor sitting right here on the B cell, it's a presenting cell. So this is helping the T cell find antigen. Remember, the helper T cells cannot find them on their own. They rely on these proteins and are attracted to them, and in turn releasing more cytokines. Okay, so we just spoke about the acquired adaptive immune system, which involves T cells, B cells, antibodies. This is the innate immunity part of your body. It's the body's natural first line defense. This immune system is rapid. So this is living and working all the time in your body. There's no adapting. It's basic. It's there. Physical barriers such as skin, stomach acid, the complement system. You have natural killer cells, and then phagocytosis of bacteria by white blood cells. And remember, white blood cells are just another form of lymphocytes. We talked about lymphocytes, T cells, B cells. We're going to talk a little bit about other white blood cells and macrophages. And then your body produces natural chemical compounds that attach to foreign substances and break them down and kill them. White blood cells, this is the other white meat, or the other white blood cells, otherwise known as lymphocytes. So macrophages and monocytes, we talk a lot about macrophages in the immune system. They arise from monocytes, and they do phagocytosis. So they basically eat other pathogens and cells and release mediators. And macrophages can alert B cells and T cells. So they tell the acquired adaptive immune system, hey, something's going on here, it's not right. Come over here and make an immune response to a pathogen. Neutrophils' propensity to IgG. So IgG, remember, is an immunoglobulin. It's one of the most numerous of the antibodies. Neutrophils are first cell to appear in acute inflammatory reaction. And you'll all know from your ICU care that whenever we look at a white blood count, complete blood count, we notice the neutrophil numbers. When that is elevated, we know something is going on acutely that we may not see symptomatically yet. Form hydroxyl radicals, hydrogen peroxide and superoxide for microbial filling. Basophils, their propensity to IgE. Remember, IgE is the allergy part of your antibody immune system. And they act like mast cells. So basophils, mast cells can be used interchangeably. Mast cells are fixed in the perivascular spaces of the skin, lung, and intestines. And they release bradykinin, serotonin, heparin, histamine, and lysosomal enzymes. And then there's eosinophils. They are seen in acute parasitic infections, but they only make up 2% of the total white blood cell counts. Really don't talk a whole lot about eosinophils, not a main player in the total immune system. Complement system. So we briefly talked about it prior because it is part of the innate immune system and the adaptive immune system. It's made up of 20 different proteins and some are enzymes. And we're going to touch on the classic pathway, although there are 3 different noded pathways in the complement system that it can be activated in. Classic pathway is activated by an antibody-antigen complex, which is part of the acquired adaptive system. It involves and initiated by C1. So C1 esterase inhibitors prevent this process from happening most of the time. C1 esterase deficiency syndrome causes angioedema. We're going to talk about angioedema a little bit later. And once the cascade is initiated, as with giving protamine, the cascade ensues. And so if any of you have given protamine too quickly, you can see some pulmonary vasoconstriction, especially if you have a pulmonary artery catheter in. Classic complement system cascade, and this is what I was speaking about earlier as the classic pathway. Remember, there's 3. This includes opsonization and phagocytosis. So opsonization basically means that the cell is targeted for death. So it's kind of like a red flag in the immune system. Lysis, agglutination, neutralization, chemotaxis, activation of mast cells and basophils, inflammatory effects that cause further blood flow to the area. So basically what this all means is you're bringing blood to the area, you're making the pathogens stick together, you're marking them for death, you're killing them with enzymes by puncturing the membrane, and causing coagulation, kind of like agglutination as well, to prevent the antigen from moving. Again, the complement system, the 3 pathways, classic, lectin, and alternative pathway. Notice this classic begins with the C1 esterase enzyme and goes down and kind of bounce off and can amplify the other pathways. Down here, opsonization, and again, inflammation, cell migration, which is basically agglutination, and lysis. We talked about acquired adaptive, innate immunities. This is passive immunity. This is where somebody else's antibodies or T cells are transfused into a person to give them immunity. These can last for 2 to 3 weeks. An example is the treatment for Ebola. If any of y'all know, but Dr. Kim Brantley was the physician from Fort Worth that was treating patients in Ebola in Africa, and he got this plasma treatment, and he even donated his own blood for survival. And the nurse who was in Dallas that got Ebola got a blood transfusion with antibodies to survive. This is current topic for today since there are clinical trials going on. Baylor is now enrolled in antibodies, which is formed by the which system? The B humoral system. And people who have survived COVID, they're making their own antibodies and giving them to somebody who cannot make their own antibodies, and therefore allowing somebody else to fight via passive immunity the infection. Another example of this is breast milk. Okay, so this is a big recap. So one, we talked about the three immunities, so acquired adaptive, innate, and passive. Acquired adaptive has two different mediated processes, cell-mediated and humoral, T and B cells, and B cells make antibodies, highly specific. Innate immunity involves several systems and acts as a first-line defense. Remember, your innate system is always working. It doesn't take much time. It's immediate. Your white blood cells, natural killer cells, macrophages. Remember, there's no memory system, like with the acquired adaptive, which can make memory cells, and the complement system, which can be activated by either immune systems. Okay, so next we're going to touch on vaccines and a little bit about how they work in the body. I know right now vaccine is the trigger word for there being a cure for COVID-19. Traditionally, though, vaccines take years, if not decades, to form. And we're going to talk a little bit about why that is in the next slide. Vaccines are a type of acquired immunity. Unlike passive, where we're just giving antibodies, we're actually forcing the body to make antibodies so that it can then elicit an immune response when exposed to a pathogen. So you can do that by one of two ways: injecting or ingesting a live or inactive dead pathogen. An example of a live organism is attenuated through mutation to not cause disease. So interestingly enough, the way they do attenuate these organisms are a lot of times they do through chicks, and all of it's like embryos, chick embryos, and allowing the organism to mutate enough not to cause a disease, but not mutate so much that it becomes something different. And that's for smallpox, yellow fever, measles. Their clinical trials are 4 phases, and the last phase, which is phase 4, is usually the largest group. So you inject a ton of people with it, and you can even have it like ready, FDA approved, while you're going through phase 4. I don't really know how or when they're going to have a vaccine for COVID-19. And there's a lot of debate whether people have started to get injected by different companies who have made vaccines. The safety factor, normally, if you can whip out a vaccine in 12 to 18 months, doing it quickly. So only time will tell. Another interesting part about vaccines is that they can only be developed by a disease that has been fought by the body naturally. That is one of the reasons why there are some uncurable viruses out there that, if the body cannot form great antibodies to it and actually survive it, then how can it form vaccines, natural immunity to it? Next few slides, I'm going to talk about the effects of anesthesia on the immune system. And there's a lot of information here. I'm just going to touch briefly on these topics. So anesthesia changes your immune system. So you have a baseline immune system, and we're going to give you some drugs and stress your body out, and it's going to make your immune system kind of go wacky. The first is, well-known neuroendocrine stress response. So stress can occur from the stress of surgery, hypothermia, hypoglycemia, pain. All of these cause immunosuppression. And NSAIDs. So the interesting thing about NSAIDs are they possess anti-tumor and anti-angiogenic properties, meaning they prevent cell growth. Tumors secrete cytokines and chemokines, leading to proliferation and angiogenesis. So basically what that means is tumors secrete inflammatory markers, making them grow, and NSAIDs can stop the inflammation to make them stop. Anesthetics cause immunosuppression. So ketamine, induction agents, volatile anesthetics reduce the total number of natural killer cells. Remember, natural killer cells are part of the innate immune system. And then opioids. Opioids trigger release of corticotropin and cortisol with the sympathetic nervous system, and then catecholaminerase release. So basically what that means is you release these stress hormones and catecholamine. So basically your body gets stressed out. These stress hormones then suppress natural killer cells, lymphocytes, and neutrophils, and macrophages. So you're basically suppressing these top are suppressing the bottom, your natural immune system, innate. And interestingly enough, narcan reverses effects. And then regional anesthetic anesthesia has no effects on the immune system, and interestingly has been shown to reduce cancer occurrence. And carefully, angioedema. So we spoke about briefly when we were talking about the complement system and C1 esterase. So this is retouching on the C1 esterase enzyme. Angioedema can be acquired, meaning you get it from something, or hereditary, genetic. It's episodic subcutaneous and submucosal edema involving the face, extremities, and GI tract, which I was not aware. The GI tract can be affected, causing severe abdominal pain. 2 causes. So release of mast cell mediators associated with urticaria, basically that's hives, bronchospasm, flushing, and hypertension. And then the bradykinin release is involved with vasodilation. This is a great picture of angioedema, or some swelling of the sub-Q tissue. So angioedema, not only do you see outward appearance of a huge swollen tongue, swollen lips, these patients can have laryngeal edema and can actually have stridor and difficulty breathing. I've actually seen a patient that has had angioedema, hereditary. And so we're going to talk a little bit about the difference between hereditary and acquired. This patient, this swelling of the tongue and lips were apparent actually in PACU, delayed about an hour after surgery. Again, angioedema, the most common form is hereditary. So hereditary. C1 esterase inhibitor dysfunction. So that C1 esterase is the number one step in that classic complement system that can cause a cascade of basically inflammation. So think of it as just an inflammatory cascade. It is there, and if it's not inhibited, so this is inhibiting that cascade. If it's not there, the cascade will ensue. So absence leads to release of vasoactive mediators that increase vascular permeability and produce edema via bradykinin. This laryngeal edema and facial edema can last 1 to 3 days. And this is triggered in about the second decade of life by stressful incidences. So, this patient that we had did not have any kind of ACE inhibitor that you think of with angioedema. We pretty much think she had hereditary C1 esterase inhibitor dysfunction and underwent a stressful surgery, and kind of a delayed response ended up having some swelling, severe swelling in PACU. I believe eyes were sewn shut. Dental cases, because you're touching the airway, and that lady I was telling you about, she was intubated, and dental cases, and then acquired. So this first one's hereditary. Acquired is by people with lymphoproliferative disorders who have antibodies, C1 inhibitors. Just basically reducing the number of C1 esterase inhibitors. That's keeping the immune system calm. ACE inhibitors can also precipitate angioedema in 0.5% of patients, and then drug-induced is thought to be because of bradykinin release. It's a treatment. So that patient we treated with is called Berinert. It's a human C1 esterase inhibitor concentrate. So we're basically giving the patient something to calm down the complement cascade naturally. That patient did not have any stridor or laryngeal edema. It was all tongue, lip, eye, face. So she was not at risk for any airway issues, although she was monitored very closely. We gave that medication dose based on her weight and reversed nicely. So prophylactic androgens such as danazol, Zolol, believe to increase hepatic synthase of C1 esterase, and then preferred treatment is the concentrate that I was telling you about, or FFP. Acute episodes involving laryngeal edema may be treated with intubation, and prophylaxis before dental work recommended. Basically having this inhibitor available. Allergic responses. So we've talked about the immune system and what it normally does. This plays into, with some antibodies, into the types of allergic responses. There are 4 types. Type 1 is what we all talk about, which is anaphylaxis, IgE-mediated mast cells and basophils. And remember, I talked about before, mast cells and basophils release chemokines, cytokines, inflammatory factors. They're kind of the same in one in terms of what they do. Type 2 mediate cytotoxicity via IgG and IgM in the complement system. Type 3 produce tissue damage via immune complex formation deposition. This can lead to then glomerulonephritis, hives, and pain. And then type 4 is marked by T-cell mediated delayed hypersensitivity. These types break it down basically by what can happen. So type 1, anaphylaxis, food, drug allergies, hay fever, and hives, IgE mediated. Type 2, mismatched blood cell destruction, autoimmune hemolytic anemia. Remember, this can cause glomerulonephritis as well. And then type 3 is going to be your immune complex formation deposition. And so rheumatoid arthritis, systemic lupus erythematosus. And then type 4 is a T-cell issue. So something like type 1 diabetes and contact dermatitis. And again, this is just a fancy picture of cells and kind of what breaks down each type. Again, type 1, IgE, right here. Antibody system triggers the anaphylaxis. Type 2 is antibody-mediated, mismatched blood. So remember, antibodies, whenever you're giving blood, it doesn't work. And then type 3 is going to be your tissue damage via immune complex formation deposition. So this can lead to some allergy-like symptoms. So this is immune complex. So neutrophil and then your immune complex. And remember, some examples are systemic lupus erythematosus. And then type 4, delayed hypersensitivity, type 1 diabetes, again, and contact dermatitis. I think with these, the most important thing to remember is really type 1, anaphylaxis, type 2, mismatched blood, type 3, still an immune system response, autoimmune, and type 4 is some autoimmune but can be delayed. Those mast cells and basophils, remember, histamine, prostaglandins, leukotrienes are released. Anaphylaxis, primary vascular collapse, occurs in 1/4 of all cases and can be fatal. There's some information, kind of a large gap, so 5 to 20,000 in this many of anesthetics. So that's a huge gradient, and so something gets just underreported or versus differential diagnosis. Risk factors, we at our facility get patients that have been there 30 times, 40 times for the same procedure, and always in the back of my mind, is this the time they're going to have anaphylaxis to the antibiotic I'm giving them? Which would be an immune or non-immune mediated? It would be immune mediated. Differential diagnosis, increased peak airway pressures, hypertension, tachycardia, cutaneous manifestations like hives, all of this can happen. And non-immune mediated, non-immune anaphylaxis, used to be called an anaphylactic-like reaction. It's going to look the same, and this is, you can have a one-time exposure and anaphylaxis and have anaphylaxis boom, and you don't have to have the antibiotic 100 times to form the antibodies. Regardless of the type, we're going to treat it the same. And so treatment is to reverse hypertension and hypoxia. So volume, remember, you're going to have a huge capillary leak from increased permeability. Epinephrine is a great drug of choice, 10 to 100 mics IV, and vasopressin or epiglucagon if epi doesn't work. Remember, glucagon is that great little drug that can increase CAMP, adenyl cyclase, and it's another drug that you can give to treat beta blocker overdose. Antihistamines may decrease manifestations, although not effective once mediators are released. So there's some conflicting evidence of should you give antihistamines. I mean, we'll give them, but remember, you just have this mass release of mediators. You can't go back. They're already working. And then steroids, often administered, again, although not effective once mediators release, although we still culturally give them in the OR. May reflect enhancement of beta agonist effects of other drugs or inhibition release of urocanic acid, which is further going to release the leukotriene prostaglandins. So there's some conflicting evidence of what you give and when. The big thing with anaphylaxis is restore your cardiac symptoms. So volume, epi, reduce the hypertension, and then protect the airway and lungs. So the patient that we were talking about earlier, so the student had, intubated patient, turned the bed around, started the normal antibiotics, vent started alarming, and peak airway pressures went really high, immediate, and tachycardia at the same time, and hypertension. So the first blood pressure, dropped, normally will drop after induction. This dropped pretty significantly, I believe in the 70s, and then went, down pretty quickly. So a huge vasodilation, immediate response. So basically, this patient vasodilated and bronchospasm at the same time, and they were treating simultaneously, and epi worked great. Resuscitated patient, did not code, but resuscitated adequately, woke the patient up and told him, you may need to have some allergy testing. Whenever we do these cases, you give a ton of drugs, and within 5 minutes, and you don't really know what triggered it. Patient, just talking about, you have to wait at least 6 weeks due to depletion of immune mediators to get tested. Sub-Q skin testing, center that can treat life-threatening reaction. And people with penicillin allergy have a 3 to 4-fold risk for an allergy to other drugs. So it's an interesting little factoid that you see penicillin allergy, you're wondering, what else are they going to be allergic to? So speaking of allergies, we're going to talk about drug allergies. And some of y'all have been in clinicals at some point and have noticed there are patients that have about 20 drug allergies. And I want to make it clear that you're going to have to do some digging. You're going to come across patients with so many drug allergies, you literally cannot give them anything. They're allergic to Versed and fentanyl and morphine and Dilaudid and propofol, etc. So you're really going to have to do some digging on some of your patients and figure out what is a drug intolerance and what is a drug allergy. The most allergic medication that we give is muscle relaxants, which is 60%, real big in red, 60% incidence of anaphylaxis type response. So the thing with muscle relaxants or any of these drugs we're going to talk about is you give them with induction. So if you have a 5-minute delay, you've given also Versed, fentanyl, propofol, muscle relaxant, and your penicillin, your ANSEP. And so these patients really needs to be pinpointed if they do have an anaphylactic reaction. What happened? So IgE or anaphylaxis mediated reaction of quaternary tertiary ammonium ions, although no histamine release can be found with high dose rock. Cross-reactivity is high, and makeup has the same compounds which can sensitize a person over time. So just putting on makeup, you build antibodies, and boom, you get a huge dose of rocuronium, and you can just have anaphylaxis. Speaking of rock, then sucks the highest incidence of anaphylaxis. And this is interesting to note. So rock, talking about IgE, so you can give a large dose of rock and it won't cause any histamine release, but it can cause anaphylaxis. And then mast cell degranulation, which is non-immune mediated. Remember, non-immune mediated kind of an anaphylactoid type reaction. You just kind of, the pathogen just triggers the complement system. Mast cell degranulation can occur with benzyl isoquinolonium compounds like atracurium. So test dosing. I've never heard of test dosing until I went to anesthesia about give a patient a little bit of drug and see what happens. I did not find a lot of information or articles regarding a test dose clinically, what that means. If I researched anything, it was more about really giving a patient a test, like a true drug allergy test. We at our facility do this in anesthesia. We give a little bit, wait, monitor them. If there's not any reaction, we go ahead and give them the whole shebang, plus antibiotic. But it's an interesting concept to me because is it going to trigger anaphylaxis so they get it, a little bit of it once those mediators are released? So doing this in a controlled setting is ideal. This picture is just basically talking about how you can have second generation penicillin, and there's side chains that can kind of make them alike in the body that are going to trigger a reaction. Mixed with propofol, low percentage, 3%, and then important note with opioids can cause cutaneous histamine release. So I've given narcotics to patients, and around their IV it's going to turn red a little. I just monitor that and tell them it's normal, it's not a reaction, just local histamine. And then IV contrast can be non-immune mediated, and you can pre-treat with oral prednisone and Benadryl. Again, the important thing with drug allergies, find out if it's intolerance or true allergic reaction. And a lot of the times we just pick a different antibiotic, but it's good to know what you can give, what cross-reacts. Local histamine release is normal. Hives, urticaria associated with IgE anaphylaxis, not normal. And so when patients have hives or rash type of response, systemic, they say they had trouble breathing, those are red flags that they're IgE mediated and probably should stay away from. Latex allergies. So something interesting about latex is that not a lot of things we have anymore have latex anymore. So we pretty much removed everything, even to the stoppers and the syringes. A lot of even tourniquets are latex free, our gloves are latex free. So we've gone away in the anesthetic world, OR world, from using anything with latex. Unless you intentionally pull out latex gloves, can you have some latex exposure? Normal Foleys as well, catheters have latex in them. Latex is a sap-like substance produced by the rubber tree. And speaking of rubber tree, these banana trees, avocados, kiwis, are from similar like trees, which is why you have cross-reactivity with bananas, allergies, and latex. True allergy can appear in 30 minutes, just because that's good through the skin. make sure you take a full history of the patient and really talk to them about breathing issues, balloons, symptoms, itching, and asthma. So we, operating room staff, and those with a history of spina bifida, have an increased incidence to form antibodies over time and then start having reactions. Autoimmune disorders. So we're going to talk a lot about autoimmune disorders in the next several slides. This is from when the body just does not act correctly. It basically kills itself. The immune system has gone awry, and you get diseases and disorders. Tolerance. So normal, the body to keep itself in check comes from pre-processing of T lymphocytes in the thymus and B lymphocytes in bone marrow. So these cells are literally checked and told, don't kill your own body, only kill those pathogens that are needed. So a misdirected adaptive immunity is a major immunological stimuli that can activate self-reactive lymphocytes. Example is Guillain-Barré, which is caused by an infection, usually with Campylobacter. So rheumatic diseases are an umbrella of diseases, and we're going to talk about a few different kinds of them. Rheumatic, as an umbrella, involve joints, muscles, bones, tendons, and ligaments. And specifically, rheumatic arthritis, or RA, is a systemic disease, and you've got some joint involvement, cervical instability, the cricoretinoid joints, and atlantoaxial subluxation, which may exceed 40% in patients, which is probably the most common one. And then cardiac and lungs, you've pericardial effusion, fibrosis, or pleural effusion. So patients with RA, short for rheumatoid arthritis, are going to come in, and they may have a lot more going on than you can tell just by looking at them. Rheumatic diseases continue, so we're going to talk about lupus, systemic lupus erythematosus. Causative factors, lots of things. Genetic, environmental, and alterations in your immunity and drug-induced, which is hydralazine. This is a multi-system chronic inflammatory disease characterized by anti-nuclear antibody production. This involves the hands, wrists, elbows, knees, and ankles, and a malar rash is basically like a butterfly rash on the face. Is seen in about a third of these cases. And this needs to be noted, the spine is not involved. With the RA, but the spine is involved. Renal disease. This is the most common cause of mortality, and transplant is indicated in 10 to 20% of these patients. When I hear lupus, or when I get a patient with lupus, I am thinking renal dysfunction. Also involved are the heart and lungs. So effusion and pulmonary fibrosis, interstitial lung disease, and then some coagulation issues, PE. Thromboembolism is associated with the antiphospholipid antibodies. So a quick note on antimalarials. Noted that this is a treatment for lupus, and there are several patients still that are on antimalarial drugs. There's two common ones, Plaquenil, which is hydroxychloroquine, and then chloroquine. And these drugs have been in the media recently due to COVID by reducing cytokines, inflammation, reducing incidence of inflammation, cytokine storm with COVID-19. So that's the relating between antimalarials right now and how they're relating to lupus and how they are the hot topic right now for drug therapy. Okay, so scleroderma, literally like scarring of the skin, inflammation, vascular sclerosis, fibrosis, and etiology is unknown, although it onsets in age 20 to 40 years with women more commonly infected. Raynaud phenomenon, Raynaud's disease occurs in 85% of cases. You have some lung, heart, and kidney involvement. So this is systemic disease, interstitial lung disease, which we've heard this again, RA, lupus, fibrotic lung, cardiac again, pericarditis, fibrous heart, and then renal vasculopathy. So renal arteries get stenosed, and just like the vascular, sure. Patients also have gastrointestinal immobility, so this leads to aspiration and GERD, and then bowel pseudoobstruction. Treatment are immunosuppressants and anesthetic considerations. So whenever you think about anesthetic considerations for any type of disease, you want to think about go from head all the way down. So head, heart, lungs, GI, kidney, liver, etc. So what organs are being affected? So heart, assess cardiac function. You may have some venous access problems because their veins and everything are kind of scarred and sclerosed for skin stuff. Intubation may be tough because their jaw's tight. Aspiration precautions, and then prolonged weakness from neuromuscular blockers due to myopathy. Autoimmune hepatitis occurs in women 70% of the time, and usually concurrent autoimmune disease is present. These patients are put on steroids and immunosuppressants. If this does not work and liver failure continues to get severe, they will need a transplant. So we have had some patients that have had a liver transplant from autoimmune hepatitis. Their body basically attacks its own cells. So let's talk about endocrine Graves' disease. This is an autoimmune disease caused by the thyroid-stimulating antibodies that bind to TSH receptors in the thyroid, activating adenyl cyclase. And basically, the thyroid's told to grow bigger and bigger and bigger and secrete more and more and more hormone. Most common in females age 20 to 40, and there could be a large goiter present. This goiter, you can see it or feel it, palpate it on a patient. It can cause some issues like stridor dysphagia, superior vena cava obstruction syndrome as well. Treatment for Graves' disease, so propranolol impairs conversion of T4 to T3, relieves anxiety, sweating, heat intolerance, tremors, and tachycardia. Also, propylthiouracil as well, or PTC. And then iodine takes 6 to 8 weeks to work. Anesthetic considerations. So thyroid storm, remember, they have a ton of T3, T4, so T4 and T3 floating around their body. And whenever you're touching the organ and you're removing it, it can release even more hormones, and it can cause cardiac instability. The goiter itself can cause tracheal deviation. So whenever you talk to these patients, you need to say, can you breathe sitting up? Are you having trouble swallowing? Do you have any dysphagia with food? Really assess their airway. There have been one or two of these goiters that we've had to do pseudo meaning they're kind of asleep more, but an awake fibrosing approach will work. Gently put them to sleep for fear that this mass is just going to completely compress their trachea. Another thyroid autoimmune disease. It's a little different because it basically just kills the thyroid gland itself. It doesn't mess with hormones. It's just eating away the gland. Therefore, the patient is going to need thyroid hormone replacement therapy. So it's the opposite. It's too little T3, T4. Too little of thyroid hormone circulating. Basically, somebody's body just slows down and gets out of whack. So delayed gastric emptying, hypodynamic cardiac function, decreased ventilatory response to hypoxia and hypercarbia. Patient's cold, they have some electrolyte disturbances, glucose is low. So their body's like, if you think of thyroid in metabolism terms, their metabolism is way slow and way off. Endocrine, a little further, type 1 diabetes. I'm sure all of you by now have, well, you either know somebody with type 1 diabetes or you're taking care of a patient with type 1 diabetes. Type 1 diabetes is basically, used to be called, juvenile onset. It's onset before the age of 40. It's T-cell mediated autoimmune destruction. And we were talking about this back with allergies. Remember, it's type 4 allergies, T-cell mediated autoimmune. Basically, this, and it's delayed. And noted about this delayed part is there's a long preclinical course of about a decade before hyperglycemia is present. So the pancreas is getting eaten alive until there's about an 80 to 90% cell loss until something is wrong. Treatments, IV insulin, a little information about giving insulin G50. These type 1 diabetic patients can have neuropathy, so cardiac instability, autonomic instability, hypovolemia. If their sugar's high, they can be dry. And then gastroparesis. If they're uncontrolled, more than likely they have these other things going on. Their sugar's way too high or it's too low. I'm usually asking them if their sugar gets low, how they feel. Some of these patients don't even feel anything until their sugar's in their 40s or 50s. They're so desensitized, and they have neuropathies as well. So these patients can be very brittle, especially if they've had it since they were, in their teens, and you're getting them at the age of 50. They can have a lot of comorbidities already associated with an uncontrolled sugar. Cause unknown, but found to have some genetic component, and disease presents around 35 years old. Loss of myelin sheath, covering absence, optic nerve damage, cerebellar damage that leads to gait disturbances, spinal cord lesions causing limb paresthesias, weaknesses, and then urinary incontinence. This disease is pretty debilitating. If it's severe and you're having incontinence and weakness, I remember, being training as a CNA before nursing school and seeing a younger lady. She may have been barely 50, had severe MS, completely debilitating. She couldn't walk, she could barely talk. This disease, severe and aggressive, can really halt a person's daily living. Steroids can be the treatment as well as interferon B, which is a drug of choice for patients with relapse remitting. Noted with MS, it's not like other autoimmune disorders. You can have, it's called relapse remitting. So basically, patients feel really, really good, and they went from really, really, really weak, and then they're able to get up and walk around, and then they relapse, and then they get worse. And the next day they wake up and they're not walking. So this ebb and flow of the disease is very apparent with MS. Anesthetic considerations. So noted, this degree change can cause exacerbation of symptoms. Regional's okay, spinal, maybe not. So it can be associated with neurotoxicity and exaggerated release of potassium phosphorylamine administration, both prolonged and resistant to effects of neuromuscular blockage has been observed. So these are kind of conflicting data. So authors think that perhaps it reflects the proliferation of extrajunctional cholinergic receptors. So basically, there are more, and because you're getting weaker, and the weakness causes them to prolong, and the extrajunctional causes you to need more medication. And going right into another neurological disease, myasthenia gravis, another autoimmune disorder where 80% of acetylcholine receptors can be lost. Characteristic of weakness and fatigue, and women more affected. For women, I think this is our third or fourth autoimmune. For women, young women are more affected. I notice this is childbearing age, and so curious to think if there's some kind of this life stressor, pregnancy, et cetera, that's causing these diseases to express themselves. Classified into 4 types, with type 3 being the most severe. So treatment, anticholinesterase drugs inhibit the breakdown of acetylcholine, therefore increasing that amount of neurotransmitter available. Protostignine, thymectomy, and then anesthetic considerations. You want to be cognizant of neuromuscular blockers, dosage, and timing. So insensitive, or you need more succinylcholine, and due to decreased number of receptors, and then they are more sensitive to neuromuscular blockers due to weakness. Multiple organ autoimmune disorders, and this is a fun one to say, ankylosing spondylitis. Every time I see this word, I think of spelunking, which is like cave diving. Chronic progressive inflammatory disease involving the articulations of the spine and adjacent soft tissues. Really a lot of these have been multi-organ. This specifically, though, affects the eyes and can exhibit as back pain, morning stiffness, improved activity. Aortic regurg noted, decreased chest wall compliance and vital lung capacity. A little different from like RA and lupus, where there was interstitial lung disease. This is decreased compliance due to not being able to move very well, so all over. Exercise, NSAIDs, immunosuppressants, and steroid eye drops for the uveitis. Anesthetic considerations, spinal column involvement, direct care. So how much of the spinal column and where is it involved? A regional anesthetic is great, but maybe limited due to spine. Paramedium approach, maybe easier than midline. And then restrictive lung disease due to costochondral rigidity. So again, this is something outside of the lung, not inside the lung, causing lung disease. Quickly, other autoimmune disorders, sarcoidosis, Sjogren's, and Crohn's. You can also throw in ulcerative colitis in there. We come across several patients daily in your practice, in my practice, that have autoimmune disorders. And just to note is to know, again, what organs are being affected, pre-op testing, intubation, and then know what medications they're on, steroids, you need to redose your steroid, immunosuppressant drugs, etc. Adaptive immunity diseases. These are diseases where the adaptive immune system has gone awry. Cold autoimmune diseases. So cold hemagglutinin disease with abnormal IgM and IgA causes microvascular thrombosis and then autoimmune hemolytic anemia and DiGeorge syndrome, which is thymic hypoplasia. Where the thymus is where B cells, T cells are differentiated. You may need a thymus transplant or T cell infusion. So X-linked agammaglobulinemia, which is a defect in maturation of B cells. And affected boys have recurrent pyogenic infections, which is basically pus infections, which remains IVG, and amyloidosis. So insoluble fibrillar proteins or amyloid in tissues. Okay, so we're going to talk about AIDS, HIV. This plays into immune system, obviously, because it's an immunodeficiency virus. This was discovered in 1981 in California. There were a subset population that were getting sick, and nobody really knew why. It's called a retrovirus named HIV-1 and 2. 50 million people are currently infected. Guys, that's a huge amount of people. Remember, we do not have a quote-unquote vaccine for AIDS, HIV. It's been around for, longer than it was discovered, but it's been around for at least 40 years. And AIDS can be attributed to 26 million deaths. It's a large number of people dying from this disease. I think the big thing between, again, talking about coronavirus and HIV virus is how is it moves? How does it move person to person? So the difference is this is a lot harder for it to move around. You have sex, IV drug use, vertical via mom to baby, or blood transfusion. It's not easy to get HIV. I know there was a lot of stigma when it first came out about how it was contagious, touching a person, etc. No, not true. It's called a retrovirus because it cannot replicate on its own. It relies on another cell, and that cell is the T cell. So it is a T cell disease, CD4 plus. So T cell, when we're talking about, there's several types of T cells. This is a T cell with the majority of CD4 receptors. Replicates in these cells, and infection and disease overtakes the body. Basically, makes the body not able to fight off normal infection. So again, T cells, B cells, B cells, antibodies. T cells are their own thing, suppressor, helper, toxic, and those are part of the adaptive immune system. And you have your innate, your complement, natural killer, etc. You can't fight off big-time infections without your adaptive immune system working. So this knocks out half of that immune system. Just by knocking that out, because this virus invades these cells don't work anymore, makes somebody susceptible to infection, and that's what you die of. You don't die of the virus. You die that you cannot fight off infection. Acute phase, marked by flu-like symptoms. So fatigue, fever, night sweats, headache. You probably think you have a flu, and that occurs 1 to 2 weeks after inoculation. Lymphadenopathy is the hallmark symptom. AIDS diagnosis. So the difference between HIV and AIDS is you have to earn your AIDS diagnosis. Just because you have HIV or HIV quote-unquote positive does not mean you have AIDS. AIDS requires a physician officially saying, okay, you have these other diseases associated with HIV, you're that sick that you officially get this diagnosis. AIDS HIV is a systemic disease. It affects the heart, lung, brain, endocrine system, blood, and kidneys. So everything's affected by AIDS HIV. You've got pulmonary hypertension, left ventricular dilatation, dementia, adrenal insufficiency, and then some renal issues as well. These are secondary to treatment or infection. Treatment for AIDS, HIV, heart therapy, which is another word for highly active antiretroviral therapy, targets the steps in the replication cycle, and there are 6 different classes. There are 6 different classes because people have to be on at least 3 different drugs at a given time. Because it affects different steps of the replication cycle, you can hit it at different places. Goal of therapy is to make viral load undetectable at 24 weeks of treatment. Anesthetic considerations, again, remember, this disease is systemic, and then you're on medication that can cause other issues. So full set of labs recommendable, CBC, PPINR, etc. Chest X-ray and EKG, echocardiogram and stress test may also be needed, and the patients may exhibit autonomic dysfunction, so may need heart line or flow track or something to monitor cardiac output and blood pressure. No anesthetic-related increases in morbidity and mortality in those undergoing heart treatment. News. I'm going to quickly touch on immunosuppressive drugs. So we've talked about the immune system, autoimmune disorders, and then immunosuppressive drugs. And so we will see these classes of drugs on patients that have immune disorders, so autoimmune diseases, and or organ transplants. And so some of these I've recognized from heart, kidney, lung transplants. Calcineurin inhibitors, which are cyclosporin, inhibits T cell activation. Side effects: cardiac ischemia and nephrotoxicity. So this nephrotoxicity piece, usually a lot of these patients will get cyclosporin levels. And steroids, it disrupts the expression of cytokines in T cells and macrophages. Remember, steroids have several other side effects: hyperglycemia, hyperlipidemia, weight gain, ulcer, and hypertension. Polyclonal monoclonal antibodies, and this includes these 4 types of drugs. The anti-thymocyte globulin is a purified rabbit immunoglobulin, and it is taken from animals that are immunized with human thymocytes. And we will actually give this for a high risk rejection kidney transplants at Baylor. We'll run at about 50 to 100 mils an hour, depending on the patient's dose. This helps boost even more their immune system along with the other immunosuppressants they receive. Interleukin 2 receptor antagonists. Remember, interleukin is released from T cells, and it can cause pulmonary edema in some young patients. Antagonists, mycophenolate and azathioprine. So we talked earlier about the autoimmune diseases, and azathioprine is a common drug that will be used. Anti-proliferative effects from DNA synthesis. So all that means is it prevents cells from overgrowing. can suppress bone marrow and cause neutropenia. And then mycophenolate is teratogenic. And rapamycin, also anti-proliferative and used in combination with the calcineurin inhibitor class of drugs. And then cell therapies. So this is something that is currently ongoing in clinical trials. Mesenchymal stem cells are basically being injected into patients with organ transplants and showing really great results from this versus giving somebody immunosuppressants, basically helping the body not form antibodies and reject organs outright. I think the key here is when you're taking care of a patient that is on immunosuppressive therapy, so pre-op holding or looking at the patient's chart, what are they on? Do they take anything? Is it steroids? Do we need to supplement steroids? What side effects can come of these drugs? That's kind of just in the umbrella of any of these types of drugs when a patient has some autoimmune disorders. Sepsis is a form of distributive shock, SIRS infection. This results from endotoxins made by the infection itself, and then they have action on neutrophils and macrophages that include releasing pro-inflammatory factors and counter-regulatory host responses. Here, we're talking about sepsis and signs and symptoms and labs. I'm going to touch a little bit on sepsis and DIC, and then interplay that a little bit with what the lab values are going on in COVID-19. They're doing COVID-19 is showing increased procalcitonin levels. We are doing D-dimer levels. D-dimer is indicative of fibrin products, so clots and break down rapidly. Sepsis is closely related with DIC. We see it a lot clinically. The immune system overruns itself and it becomes hypercoagulable. Use up platelets, microemboli, and then clot breakdown. So they go into a hypercoagulable state and then use up all their clotting factors and then start to bleed. And it's interesting because microemboli has been shown in lots of the COVID-19 patients. I know in our ICU, the ICU intensivist has mentioned that this is a big indication in this disease process of microclots. So D-dimer procalcitonin is indicative of bacterial viral infection, usually released by the liver, and just basically is alerting the provider that an infection is going on. And then C-reactive protein as well. So increased CRP levels, obviously, we're talking about it with sepsis. These are also elevated in COVID-19 patients. It's just another indicator of inflammation and something going on in the body, that there's a high likelihood that there's a huge infection. And this is made by the liver and easy to check and kind of see what these levels are. So one more lab I'm going to talk about is ferritin levels. There have been high ferritin levels, not necessarily associated with sepsis, but with cytokine storm and increased immune response to COVID-19. Ferritin, it binds, it's responsible for intercellular iron storage. Increased levels can indicate virus or bacteria in the body as well. And the free ferritin, if it's floating around free, it is inducing macrophages to release cytokines, which is further contributing to the inflammatory response. This is the nitric oxide in sepsis. This is a key player in inducing vasodilation. These endotoxin / cytokines, we've been talking about cytokines a lot in this lecture, can induce NOS, this is nitric oxide synthase, and cause this reaction, which is vasodilation. Vasopressin acts here, so it kind of prevents this cascade from happening. The nitric oxide release and then the vasodilation in sepsis. Treatment for sepsis is directed at broad antimicrobial therapy. So you'll see these patients on several different kinds of antibiotics, trying to pinpoint what the bug is and trying to kill it. Early goal-directed fluid therapy. So goal-directed fluid therapy, we are using fancier ways of measuring fluid responsiveness and having a flow track, art line, SpO2, if a swan is available. So you're giving fluid to a means to an end. You're not just slamming them with fluid. Remember, they're vasodilated. They have a huge tank, and so you can volume overload these patients. And just giving volume, you're filling up that tank. And because of the capillary leak, they will have some, third spacing if you just overdo it. Pressors, blood sugar management, hyperglycemia can actually exacerbate infection. It's kind of a slippery slope of infection causing the hyperglycemia and then that making the infection worse. Vasodrip, we talked about vasopressin, steroids, reduce inflammatory response. Usually these patients, we talked about end organ damage. These endotoxin complexes can, kind of clog up the kidneys and then make the kidneys work in overdrive, and the kidneys then cannot correct their own acidosis by producing bicarb. So it's kind of a multi-organ, one thing affects another thing affects another thing. It's just a picture of, gram-negative bacteria, endotoxin release complexes. These monocytes and macrophages then release inflammatory mediators and causes the endothelial damage and systemic effects. So basically, this is producing a big immune system response for people. Here's the references I used, Stolting, Miller, Barish. I really hope you enjoyed today's lecture and learned something from it. I know that this topic of immune system is just, in my mind, a hot topic because we're talking about COVID, we're talking about how people's immune systems are responding, we're talking about vaccines, treatment, drug treatment, antimalarials. To me, thinking about the immune system and learning a little bit more about it is at the forefront of all of our minds, trying to grasp how this virus is wreaking havoc on so many, and then not on others. And a big part of it is how much virus is in the body and how the body's responding. Thank you, and y'all have a great afternoon.